how did these drugs get approved? The FDA knew these data. Here are the FDA approval. Here's the FDA approval criterion. You have to have 2 clinical trials showing a statistically significant difference between drug and placebo. There's no limit to the number of trials that you can conduct. Maybe you need to conduct 10 trials in order to get 2 that show a statistically significant difference. That's okay. 50% of the trials, in fact, are negative. Negative trials don't count. And clinical significance is not considered. It's treated as irrelevant. So how then should depression be treated? Well, one thing that's been suggested is prescribe antidepressants as active placebos. After all, the placebo effect is large, and you can't give people placebos and tell them you're giving them placebos and work. You can't lie to them because that's unethical. I believe it's unethical. I believe in the autonomy of people who are going to see clinicians. They shouldn't be lied to. But, these are active medications. That's true, they are. And if they evoke the placebo effect, and that's primarily what they're doing, that might be an ethical way of getting the placebo effect. And, of course, the problem is you have to weigh the benefits against the risks. The benefits are negligible. Side effects include sexual dysfunction, long-term weight gain, insomnia, diarrhea, nausea, anorexia, bleeding, forgetfulness, and down the list. And I present these data to doctors, and they say, no, 70 to 80% sexual dysfunction. I've now seen actually estimates over 90%. Here are the actual data. That's the amount of treatment-emergent sexual dysfunction. That is, sexual dysfunction developing after being given treatment. Here it is with the red circle on placebo. Here it is for SSRIs. Between 70 and 80% of patients getting treatment-emergent sexual dysfunction, not having had sexual dysfunction before, but being sexually dysfunctional after being put on the drug. And these are essentially addictive drugs. 30% of people trying to get, I've seen estimates 30 to 50% of people trying to get off them experience a withdrawal syndrome. And it's not just the patient who experiences it. If a woman is taking antidepressants in pregnancy, 30% of the neonates born to women who were taking antidepressants show a neonatal abstinence syndrome, which includes things like a high-pitched cry, sleep disturbance, tremors, gastrointestinal disturbance. The exact same abstinence syndrome shown by the neonates, the babies born to mothers who are on amphetamines, barbiturates, benzodiazepine, cocaine, morphine, and heroin. There are other health risks. In children and young adults, there's an increased risk of suicide. In the elderly, there's an increased risk of stroke and of death from all causes. Pregnant women, there's an increased risk of miscarriage. Babies born, an increased risk of babies being born with birth defects, hypertension, autism. Among everyone, an increased risk of diabetes and an increased risk of relapse. And here's the other thing that people say, an increased risk of relapse. You got to be kidding. Although if you heard Robert Whitaker's excellent talk before this one, you'll know that the data on that are very clear. Here's one piece of data on that, and that's a study done by the National Institute of Mental Health. It's a gigantic study, a collaborative research study comparing cognitive behavioral therapy, interpersonal psychotherapy, a tricyclic antidepressant, imipramine, and placebo. And here's the rate of relapse from people who had improved. There was no difference in improvement between these 4 groups. Among the mildly, moderately depressed patients, differences were non-existent. Relapse rates, however, significantly higher. There's about almost 20% of patients who would not relapse on any of the other treatments will relapse if they've been given an antidepressant. Here's another study, if that one's not enough for you. In this study, people were either given an SSRI, an antidepressant, or put on an exercise program, or given both. Maybe the two together will work better than one alone. 4-month remission rates, excellent. Really unusually good. And no difference between the groups. Relapse on the SSRI, close to 40%. On the exercise program, only 8%. Well, what about if you put the two together, the exercise and the SSRI? Goes way back up again. Adding an SSRI to the exercise program quadrupled the rate of relapse. Well, is exercise a placebo? Could be, but consider the side effects of antidepressants and then think about the side effects of exercise. Which placebo would you rather have? Maybe we should prescribe placebos. Well, again, there's the ethical problem about lying to people, and then we think that if the received wisdom is that if you know it's a placebo, it won't work, although there are actually some data suggesting that may not be the case, but I won't get into that now. Fortunately, we don't have to, because there are many alternatives. There are many alternatives. These are the ones that have been subject to the most data, most clinical trials. Here's what you get in terms of average symptom reduction on antidepressants and on placebo. And so what you want is something that at least performs as well as placebo, hopefully a little bit better at least. Being put on a waiting list, that's the worst thing you can do. Standard care, which often involves antidepressants, no better than placebo. Psychotherapy, a little bit better, about the same as the antidepressant. Put the two together, psychotherapy and antidepressant, no benefit beyond giving either one alone. Exercise, same thing. Acupuncture, same thing. So, and I suspect many other things. Meditation. We know mindfulness is not in that data set, but mindfulness meditation, there are good data on. So how should we decide about treatments? Well, when treatments are equally effective, prescribe the safest. And that's certainly not going to be an antidepressant. When they're equally safe, prescribe what the person wants. Let the patient choose. Well, we know if you give patients a choice between antidepressant and psychotherapy, 3 out of 4 would choose the psychotherapy, given the choice. So we don't have to prescribe placebos, but I wish we could. I love placebos. I told you that. I was addicted to placebo research, and I once had a dream. It was while I was back in the UK. In my dream, I dreamed that I'd woken up in the morning and opened my favorite UK daily newspaper. It's actually called The Independent. I put The Dependent there. And I read that placebos had been approved by the FDA in doses ranging from 1 to 40,000 milligrams. And I was happy. I was so delighted when I woke up and it was about that dream. And I thought, gee, wouldn't that be great? And if we could prescribe placebos, we could also advertise them. You can't advertise drugs in the UK. This is one of the few countries where you can. But, we could advertise. And I wondered, what would a placebo advertisement look like? And I imagined it would look something like this. Prevaricaine, a genuine placebo treatment, tested in more clinical trials than any other treatment. So powerful, it's the standard by which all medications are tested. So effective, it's used in the treatment of thousands of ailments. Safe enough to be given to infants, the elderly, and pregnant women. And I have to warn you, it may put you off medications that produce side effects. Remember, if it's a placebo, you can believe in it. I'm about to conclude, and I thought I might conclude by reading a poem of Shakespeare's. But then I thought, why should I? He never reads any of mine. Still, I can't resist this one. It's Shakespeare's Ode to Placebo. Friends, Placebans, Floridians, spare me your tears. I come to praise placebo, not to bury it. The evil doctors do lives after them. The good is often part placebo. The medical world's a stage, and placebos merely players. Each one plays a different part. This one Prozac, that one morphine, and nothing is true. But thinking makes it so. And I thank you.